Is it audible? Check. 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 Is that okay? Mr. Shrikant, are you there? I'm going to start the event. Good evening, everyone, and thanks, Dr. Vijay, for this wonderful opportunity to initiate this educative program of teaching the postgraduate under the auspices of Maharashtra Orthopaedic Association and PUNEORTHOPAEDIC Association, along with JEHANGIR Hospital in Pune. I think it's a great and wonderful initiative by the hospital, Dr. Vijay, and the postgraduates, and also the team here who have been working meticulously to make this program a great success. With this brief introduction, I'll directly go to the nuances of brachial plexus injuries examination. I think as a postgraduate, we might feel that it's always a googly when you see brachial plexus injury and really scared to see or scared to examine and think that this case should not be in the final exam. Then I wish that all of you get each one a brachial plexus case and then you cakewalk and they should pass through the exam as easy as it will be. So just a matter of calculation of how to examine a brachial plexus injury. In this 20-30 minutes, I'll let you know how to examine, and then probably you'll be an idea of how to examine. These are my disclosures, and I get royalty from these books and most of the things. These are the disclosures, and most of the talks are taken from these books. Can it hear? Want the mic on? Am I audible now? I think we can manage. The echo is not a problem. Can you go ahead? Yeah, I think we're ready now. Okay. The mic. Is it okay now? Perfect. So the most common presentation we come across any brachial plexus injury is a wrist drop. Most of them think that it's a wrist drop, and we don't look much ahead of it. We think it's a radial palsy, but we need to look more ahead of it. Or sometimes we see patients with a absent flexion of the thumb and the index finger. We think it's a high medial palsy, and then we forget about examining the other parts of the brachial plexus injury. Sometimes we see this combined claw hand in this patient, and we also forget to look the proximal most part of the injury. So these are the different patterns of brachial plexus injury you come across in any clinical practice. It could be a complete palsy. It could be an involvement of the shoulder alone, or it could be a partial brachial plexus palsy. So these are three main patterns which you come across. You see in any clinical practice. So this sort of patients come to you. Either they can lift the shoulder, very difficult to lift it fully, or completely unable to lift with complete wasting of the entire upper limb, or a part of the upper limb is working. So it could be long case or a short case. And what we need to understand is that this is very simple. You all know that the brachial plexus is formed by C5 to T1. But to keep it very simple, you not have any confusion about how many what supplies and all this. It's very simple. C5 is the one which supplies the shoulder function. Just a simple calculation. You keep C5, the shoulder function is taken care by the C5. The elbow function is taken care by the C6. Elbow extension. I'll keep the hand on. Elbow extension is taken care by the C7, and rest of the hand function is taken care by the C81. So forget all these things, diagrams which makes you confusion, what to remember, when not to remember. It's very simple. The shoulder is not functioning, it's going to be a C5. In addition to shoulder, elbow cannot be flexed, it is C6. In addition to that, if the elbow cannot be extended, C7. And the hand functions are not working, it is C81. So very simple for the postgraduate to understand. If you see any patients from far, you can make a diagnosis. Will you pass the exam or not? You can pass it. Beyond that, what we need to understand is how you clinically examine the brachial plexus patient, how to come to a diagnosis. We don't know, or we don't want how or which surgery you are going to do. You just need to know how do you examine the patient and how do you come to a diagnosis. With this understanding, there are two simple patterns of injuries. You must have come across any diagnosis in the MRI or in anything. There will be a called as pre-ganglionic injury or a post-ganglionic injury. You know that this is a diagram which says that it's how a normal dorsal root ganglion and then the rami divides into two, ventral and dorsal. They come from the spinal cord. They form a dorsal root ganglion here, and after that comes your spinal root. These are the roots which supply the paraspinal muscles. This much you understand more sufficient. More technically, you understand there will be a lot of confusion. So if you see any injury here, beyond the dorsal root ganglion is called as postganglionic. If you see any injury, something close to the spinal cord or proximal to the ganglion is called as preganglionic. So preganglionic are something which are completely outside the spinal cord. Postganglionic is something which can be a rupture or it can be injury beyond the ganglion. That's what you must understand in the differentiate between the pre and post. So if you want to inspect, there are a simple set of tables and templates where you need to present in any examination. The examiner wants to know the pattern. You inspect, you palpate. If possible, is anything additional to that, you can do all other examination. And then you come to the motor, sensory, and special test. And the TINALs at the last. This is the way the examiner would like to see and also like to hear how am I going to present in a long case. So one inspection, what are you going to see? So you see any patient from the distance, you can say what is the diagnosis by all these calculations. Apart from that, you need to present in a systematic manner to pass the exam. Not telling the diagnosis is sufficient. How do you clearly present the case to the examiner and how are you going to pass the exam? So inspection, what are the things you need to see in the inspection? What are the things you need to look for? See, okay, once I finish this presentation, probably you can examine the patient for 5-10 minutes and anyone can present with all these patterns I described. You can quickly understand how I'm going to present to you and then you can start presenting. That will be very easy for you. Now, in any brachial plexus injury, you'll see a lot of scars or bruising in the part of the shoulder. One, because they could have associated shoulder fractures, proximal humerus fracture, or a clavicle fracture. It's a very common pattern you see. So if you see anything in the inspection, a scar, a bruise, or some clavicular fullness, you need to mention that. In addition to that, there will be some clinical sign to say these patients have a paralysis, complete paralysis. What happens? The patient is completely paralyzed. Say, for example, this is completely paralyzed. So it sags down because of the gravity. In order to compensate that, what they do, they lift to the opposite side. So this is one classical sign which tells you that this patient has a complete paralysis. The entire limb is because of the gravity is being pulled down. To compensate that, he's just using a compensative mechanism to lift so that he can balance or can keep the limb as in a neutral position. So any patient you see is compensatory lifting the injured side. It means that it's a completely passed. So this is all clinical signs which tells you that you are focusing towards a complete brachial plexus palsy injury. Now with this picture, can you see where is the lesion now? There's a compensatory lifting on the right side. On the right side, there's a compensatory lift. Patient has a complete palsy on the right side. To compensate that, he lifts on the right side. The left side is slightly lower. And also you see, the patient also tilts something towards the right side. He tilts the neck towards the right side, injured side, and compensates for the paralysis right side. So this is one clinical sign which says you that this patient has a complete brachial plexus palsy. And TINAL sign is that a localized portion of a nerve which is ruptured, that's beyond the ganglion. For all postganglionic, they'll have a TINAL sign. So particularly localized TINAL sign, if you tap on the particularly localized, either the supraclavicular region or the infraclavicular region, the TINAL sign which says that he has a tingling sensation to particular portion, that helps you to say which level is he was. If, for example, you tap on the supraclavicular region, He says that it's going to the deltoid or to the biceps. It means that it is C5. To tap, he says that the tingling sensation is going to the thumb, C6. The dorsum of the middle finger and the other portion, C7. And to the little finger and the ulnar-most portion, C8. So these are clinical findings. It tells you that these are the clinical findings suggesting of a diagnosis. By a Tinel sign, you have such a value that you can come to diagnosis of this brachial plexus injury, and this has a Tinel sign. So such is the value of a Tinel sign. Additionally, if you inspect the patient closely, watch the eyes, what's the difference between this patient? Both eyes are not normal, both eyes are not the same size and symmetry. So there's a ptosis. Ptosis is where there's a shortening of the eye because of the upper eyelid is weak. And these are all because of involvement of the C8 T1 preganglionic injury. And these sympathetic fibers, which are very closely linked to T1, these avulsion injuries, they have a harness syndrome. So the patient, if you closely watch a patient with the ptosis, you can clearly say that this patient has a C8 T1, probably a complete avulsion of brachial plexus injury. So these are the one which says you that an avulsion injury or a rupture injury. You see a harness syndrome, there's definitely involvement of C8 T1. And you look for the muscle wasting. So you're going to examine this patient short while, and you present in the inspection what are the pattern of wasting you see. If you see that there is a localized or wasting in the entire shoulder and a normal contour in the forearm and the hand, means that this patient has involvement of shoulder alone. You're only dealing with C5 or C6 region. So this is one clinical finding you're going to say to the examiner. Look, I'm going to only present you a case of a partial or a C5, C6 brachial plexus injury. Because my inspection finding is that there is a complete wasting in the shoulder. And the contour of the biceps is also wasted or lost. Beyond that, the contour of the forearm is comparable to the normal side. There is no wasting in the hand muscle. This conveys a message to the examiner that you're inspecting a C5, C6 brachial plexus injury. So these are all the points which help you to come to a diagnosis, especially in brachial plexus injury. And these are the grading. As we all know that muscle grading is based on the MRC power. So these are the things which says that this patient has a power of 4/5 or 3/5, 2/5. So the examiner might want to know what is the power of the biceps. You say that there's a biceps contracting or not contracting. At the same time, you should also say that the complete paralysis or complete weakness of the biceps. So you should show that the MRC grading is 0 or 1 or 2, whatever it is. We'll start from the top. Okay. So now this is the way you start from examining brachial plexus from the proximal to the distal, because this gives you an idea which are the muscle you should check for. So to make it very simple, we should always start from the trapezius muscle. You look for the eye, see whether the ptosis or not. Look for the wasting, and all these inspection palpation is over. Then come back to the motor examination. We're going to look for the motor examination. This is how you do a trapezius examination. Now, make the patient sit comfortably. Most of them, they have associated injuries like fractures in leg or forearm, whatever it is. Make them comfortable sit and ask them to shrug the shoulder. You need to stabilize the shoulder, shrug and feel for the trapezius at the back and also at the clavicle portion. The trapezius portion is completely examined from the back and also the clavicle portion. So most of the time, clavicle is the trapezius is uninjured. It's very rare to see any trapezius injury unless otherwise you have a gross involvement of C4. Then other muscles are the rhomboids and the levator scapulae. Why specifically we want to say? There are few muscles which you need to understand, test it before you go for the other examination and you can come to diagnosis. The rhomboids and the levator scapulae are separated to the dorsal scapular nerve. Why specifically dorsal scapular nerve? Now we'll come to the roots of the brachial plexus. You know that there are roots which form C5 to T1 in the brachial plexus. Now we are going specifically to the roots. We will get more easier now. There are two muscles which are supplied from the proximal root, C5 roots. They are the rhomboids and the levator scapulae muscles supplied by the dorsal scapular nerve. So this is the nerve which comes from the root. So if you check this nerve and the muscle, you can say that this patient have a preganglionic injury. These roots are avulsed, so this muscle is not working. Or this muscle is working, then there is no injury to the roots. What are the roots? Can be C5 or C6. We come to that. So now we'll check the rhomboids and elevator. This is one way of checking the rhomboids. Ask the patient to lie prone, lift extend the upper limb without bending it and feel for the rhomboids here. Rhomboids are somewhere on the medial angle of the scapula, or this is the other way of checking the rhomboids. Can you see the contraction of the rhomboids here? This is a normal patient. This is where the rhomboids contract. It's difficult to differentiate between levator scapulae and the trapezius because both have similar function. But if you could test the rhomboids major and rhomboids minor, you say that the dorsal scapular nerve is injured and it's a root injury. And the diagnosis becomes a preganglionic injury. And again, in this patient, you see the scapula here. This is the midline. Because the rhomboids are weaker, rhomboids are not acting, there's a widening of the scapula because of the weakness or absence or paralysis of the rhomboids. So this is one quick example. If you see from the back, this is a normal angle of the scapula from the midline, and this is the distance between the inferior of the scapula and the midline because of weakness of the rhomboids muscle. This is in a patient. So he has a C5, C6 weakness, where you can see there's obviously a dipping, a prominence of the scapula, the medial border of the scapula. There's wasting of the rhomboid. So this is one quick test to say that this patient has a proximal level of injury, that is at the root level. There are two roots which comes from the root level. One is the dorsal scapular nerve C5, C6. The other is the long thoracic nerve which supplies the serratus anterior C5, C6, C7. If these two muscles, if you could come check, ask the patient, turn, check for rhomboids. If it is not there, it's a root injury. Test for serratus anterior. If it's not there, it's a root injury. Rest of them all are not root injury. Understand? This is one way of checking in a patient who has a C5, C6 top. The other root is the long thoracic nerve. We call it the nerve to serratus anterior, or is supplied by C5, C6, C7. All branches from the roots. So if you could test this, and this will say that it's a root injury or not. This is one quick example. See, there's also a wasting on the medial side of medial scapula. Addition to that, there's elevation of the scapula higher level. Meaning to say that scapula is winging. So the left, you compare the normal motion, and the right you can compare. One way of testing is that if the patient has a good for triceps, because most of the patients who are C5, C6, they don't have a serratus anterior. So they'll have a triceps, so they can ask them to sit comfortably and just extend. Ask them to try catch something. Sit, try catch something. So this initiation of movement, this initiation of scapula is done by the serratus anterior. You can see in the patient here, the routinely described method is push the wall. Because most of the patients, they don't have a good triceps. If you don't have a good triceps, you cannot hold the elbow in a straight position. Always it bends. It bends. So this one patient where it does not have triceps, we're trying to do it. You can see the scapula here. The scapula is, there's a weakness here completely. The scapula is winging and always going to protraction. This is because of the winging of scapula and absence of serratus anterior. Other simple test which is described by Vijay Malshikare is ask the patient lie down comfortably. Ask him to hold something which is there. Hold something which is there. Hold something. He's like trying to receive. And also feel for it. Exactly at the between the anterior axial line and the posterior axial line. There lies the serratus anterior. So feel for it. It's not confused with the latissimus dorsi. It's somewhere in the posterior axial line and also at the inferior scapula. Keep the hand there and you feel the contraction of serratus anterior. Because these are two clinical tests which will say that it's a root injury. You feel for it. This is where you need to feel for it. Ask them to lift and try something, hold something, lift and hold something. That movement is done by the serratus anterior. Now, examiner asks you that it's a C5, C6 root injury. How will you clinically say? What are the two tests you see? You check for the rhomboides major and rhomboides minor and the serratus anterior. Now you can convincingly say that to the examiner, this patient has C5, C6 root knee. We'll come to the little lower level, the trunk level. We call as the Erb's point. Okay, so only one nerve which can be examined at the Erb's point is the suprascapular. What does the suprascapular nerve does? It supplies the infraspinatus and the supraspinatus. So what are they? They are the initiation of the shoulder abduction. Supraspinatus are the initiation of shoulder abduction, and external rotator. More is an abduction, but the infraspinatus are the strong external rotator. If you could do these two tests, you can say that the injury is at the trunk level. If this is not there, the injury can be at the trunk level. So rather you see the picture, which is confusing. You forget the picture, but you come as sequentially and diagnose all those muscles. You will come to know where is the injury level. So now we are checking at the trunk level. There's only one nerve which need to test, that is the suprascapular nerve, supplies the infra and the supraspinatus. So this is the one which initiates the abduction. Stabilize the shoulder, because that is done by the deltoid. Stabilize the shoulder in normal patient. The initiation of abduction of up to 30 degree or even more is by the supraspinatus. More of an initiation of abduction. See, this is a patient where I'm just stabilizing the shoulder. He could do it. That's the initiation of abduction. That's not a deltoid. He could do it. See, that's the initiation of abduction. He is doing that. Similarly, for the infraspinatus, keep the arm close to the chest. Ask him to external rotate. This one way is also ask him to do, and also at the same time feel at the scapular region. The spinal scapula above is the supraspinatus, below the spinal scapula is feel for it. If you feel the contraction, you can say that this is working. Beyond, because patient may not have a power to do it, but there might be some contraction. You can say that this is involved or not involved. This is in a patient. See, he's trying to do external rotation, and at the same time I'm feeling for it. Supraspinatus, infraspinatus. I'm feeling for it. Without feel, you cannot say that is working or not working, because there might be some contraction. Now we have come to the trunk level. So up to this level, I think we are much confident that we can say which part of brachial plexus is in charge. Either it's a root level or at the trunk level. And beneath are multiple roots, which are quite confusing, but very easy for you to understand. Beyond the trunk, these divides into two divisions. The upper trunk divides into two divisions. The middle trunk has only one division. The lower trunk has two divisions. The middle trunk, C7 or middle trunk, again divides into two divisions. So all these upper trunk, middle trunk, and the lower trunk divides into two divisions. All the posterior divisions, they form the posterior part. The anterior divisions of the upper and the middle forms the lateral part. And the middle, the lower trunk, the anterior divisions form the medial part. Very simple. This much you understand, because the picture will not say anything. Picture will confuse you. You will not forget. You will not remember anything about it. Now the divides. There's a division of the at the trunk level and formation of the cord level. Division of from the trunk, formation of the cord level. So we have three cords: posterior cord, and the lateral cord, and the medial cord. So now we'll come to the posterior cord. At the posterior cord, we know the mnemonic. Very easy for us to understand. The ulnar, ULNER, ulnar, or can be ultra, whatever mnemonic you have. So examiner asks you, what are you checking for? So I've checked for the root level. These muscles are not working. I check for the trunk level. These muscles are not working. Now I'm looking for the cord level. These muscles are not working or working. So what muscles you are going to check? The posterior cord. We'll come to the posterior sequentially posterior cord. The first one to check is the latissimus dorsi. There are two ways of checking it. Simply, it's an adductor and an internal rotator. Latissimus dorsi is an adductor and internal rotator. To stabilize the arm, ask him to adduct, feel for it. This is where you need to feel for the latissimus dorsi. The other simple way is that this is a normal patient. He'll have a normal latissimus dorsi. The other way of examining a patient who has weakness, complete weakness, or partial weakness is that ask him to cough. The initiation of cough is done by the latissimus dorsi. So keep the hand along the inferior angle of the scapula. Ask him to cough. If you feel the contraction, it is working. It's a simple way. All the examiners will understand because it's a standard way of checking. These are all specific way of checking it. We do not want to know the specific way, but simple way of communicating to the examiner is mandate. So this one patient, see, I'm asking him to cough because he has complete weakness around the shoulder. He cannot do or cannot understand what I want to elicit. So I'm just asking him to cough and feel for the contraction. There is contraction. You can see the contraction in this patient. This is a patient who does understand. I could do the test here, stabilize the shoulder, ask him to adduct, at the same time interlocate. He is doing it. It's very difficult to differentiate between the latissimus dorsi and the teres major because both have the same function. They are called as conjoint tendon. Examiner will not go into much detail about that. You need to understand that. Now, there are two heads of the pectoral major. So, one, you can easily say the nerve root level. You need to remember that. You know the divisions from the anterior, the upper trunk. There are two divisions. From the anterior divisions of the upper trunk and the anterior divisions of the middle trunk. They form the lateral cord. So that also supplies a part of the pectoral nerve. Okay, what will be the nerve root level? Because that is by the C5, C6, C7. Something between C5, C6, C7 is the one which forms the lateral cord. Medial cord also has a portion where the anterior divisions of the medial cord forms the anterior divisions of the lower trunk forms the medial cord, which also supplies a part of the pectoral nerve. So if it's a medial pectoral nerve, it should have a C81. If it's a division from the lateral cord, it should have a C5, C6, C7. So this is a simple way of differentiating. That portion is supplied by the C5, C6, C7, and this is different. So we need to differentiate between two nerves. And also we need to look for the different portions of the pectoral major because this will help you to say which part is injured. Because this, in the entire brachial plexus, one muscle which has all innervation is that pectoralis major. It's from the lateral cord also and also from the medial cord. So all the nerve supplies the pectoral nerve. If you could differentiate between these two, you will sail through which portion is injured. So there are two fibers. One are the sternal fibers. This is one way where you stabilize it with the shoulder abducted, stabilize it and feel for the portion which is attached to the sternum. He asks them to adduct, a strong adductor of the shoulder. The other portion is the clavicular portion. Here, the patient needs to rest in the table. You need to rest in the table so that the sternal part is relaxed. Ask him to then contract. There are two different ways of checking this portion because the upper one is supplied with C5, C6, the lower one is supplied with C81. This is one idea which differentiates what part of injury is what. Sternal fibers. And then the part of the posterior cord is the ulnar, is upper subscapularis, the lower subscapularis, nerve to latissimus dorsi, axillary nerve, and the nerve. This is the mnemonic we remember these days. So you've done all those investigations, they're coming to the axillary nerve. The axillary nerve supplies the deltoid and teres minor. Very good. So these are all very important because these are the questions which examiner might want to know. It's very easy for them to examine the deltoid, but these are questions very important. So there are three parts of deltoid we should understand and examine. The anterior portion of the deltoid is called the anterior deltoid, the middle deltoid, and the posterior deltoid. These are the important things we need to examine. So this is one way of checking the anterior deltoid. Ask them to relax, keep their hand on the table, lift it, and you feel for the anterior deltoid. This is how we check for the anterior deltoid. Feel for the anterior deltoid. At the same time, you feel for it. And the posterior deltoid is one which has a sort of extension and also retroversion of the shoulder. So this one way is that ask him to abduct, at the same time extend. That muscle is, that part of the posterior deltoid does this function. So he has a weakness and also paralysis of the entire shoulder. He cannot abduct, at the same time extend the shoulder. So how do you differentiate between a supraspinatus and a deltoid? One simple question which examiner wants to ask. The initiation of abduction is by the supraspinatus. So it cannot go beyond 30, 40, maximum 50 degrees. A complete abduction is done by the deltoid. Initiation, stabilize the shoulder, ask him to abduct. This initiation is by the supraspinal. This much you convince the examiner. It's very easy to differentiate between these two. This is one simple test. See, he does an external rotation. And this is the initiation of abduction. This is not deltoid. This is the differentiate between two. And this is one way this patient had isolated deltoid palsy. This is called as a sprawling test, which is published by Jayam. Ask the patient to forward, bend forward, lift both upper limb. This is one way of testing the posterior deltoid. This is one test where you can also check the isolated palsy of deltoid, where something like a sparrow tail. So one side will go up, the normal side will go up, the injured side will not go up. This is the deltoid palsy, and he is Jayam. I met him in one of the American Society meeting here. Easy to differentiate teres minor because it does the role of the external rotation in shoulder. Difficult to differentiate the upper and the lower subscapular nerve because this is one simple test where you can ask the patient to stabilize it with the arm abducted and interrotated. Stabilize the shoulder and ask them to abduct. This is one way of checking the upper and the lower subscapular. Most of the patients may not do it. So now we have finished which card we have finished? Posterior card. Now we'll come to the lateral card. These are the anterior divisions of the upper and the middle trunk. Will carry the number of C5, C6, C7. So lateral cord will always have C5, C6, C7. Medial cord divisions and medial cord branches will have invariably C81. If the examiner asks, you can blindly say that it's C81. For a portion of anything on the lateral cord, you can say C5, C6, C7. Hair should be there because all these divisions of posterior divisions, they form the posterior cord because they might have all the nerves involved. So those are the ones which you need to be very cautious, especially the pec major and also a part of latissimus dorsi, which will have C6, C7, C8 also. So this is one easy way of saying the root value. Examiner asks you to write anything on the lateral cord, C5, C7. So one simple example is the muscular penis nerve. It supplies the biceps and the coracobrachialis. So the examiner might want to know how you differentiate between how to check for a biceps and how to check for the coracobrachialis or a brachialis. Difficult to differentiate between biceps and coracobrachialis, but you can check a brachialis. So biceps is a strong elbow flexion under supinated. So all you need to do is keep the forearm supinated, and then check for the flexion power. This is one way of checking the power of the biceps. If you want to check the power of the brachialis, any idea? Mid-prone position is the way which you can check the brachialis. Feel for it. Ask the patient to bend and feel for the brachialis. So brachialis, they carry C5, C6 because they are from the lateral part. It should be C5, C6 plus or minus 7. And then once we come down, the triceps, I said triceps are part of C7 something, so it includes C7, C8 even. This is one way of checking the triceps, which is, of course, obviously against the gravity. There are other ways which you can check with the gravity eliminated. Ask the patient to lie down, gravity eliminated. If they can extend the triceps, it's fair enough. You can say this patient has a 2 plus or 3 triceps power. And this is supinator, where you should ask the patient to sit comfortably resting on the table, and then you can feel for the pronation and the supination. While doing the movement, you should check for the supinator power on the dorsal aspect of the forearm, and also the pronation you should check on the volar aspect. Though both the powers should be checked. Not merely doing will help you or will convince the examiner that the test. So now this is the mnemonic which you have followed now, and anyone who wants to take this video and let me know what is the diagnosis from clinic. Anyone volunteer. So far, we have just come across all the basic nuances of examination. Anyone can just try. No harm in it. Because at your age, I did not know what is brachial plexus. Now we have the idea of brachial plexus. Anyone can volunteer and just say, just watch this video and just let me know what is this diagnosis. Who is going to volunteer? You're going to volunteer better, or Vijay is going to say somebody. Who is going to say? Anyone? See, because brachial plexus, unless you understand, really, it's a fun. Nothing like hidden fact here. Give a try. Nothing harm. Anyone? Anybody in the ladies' side? Anyone? Man? Okay, you want to give a try? Just, get up, just get up. Just watch this video. So he has a good wrist extension, good finger function. All this finger adduction and abduction is good. Basically, the hand function is good. This is pronation, masking due to pronation. I'm feeling for the pronation there. You could do. Okay. We'll come back to that. It just got stuck. Okay. Let's see this. So the other way of examining little down the median and the ulnar nerve. I'll quickly run through this video. I think most of us would know the way of managing the peripheral nerve injuries. Probably if you have time, we can discuss that. The flexion of the MCP joint and the extension of the IP joint is basically by the lumbricals and the intrinsic. This is one test which I have shown you to check for the lumbricals and the intrinsic. The epiductors and the adductors, dorsal intraosseous and the palmar intraosseous. Simple test of examining this patient. This is flexing the MCP joint, extending the IP joint. And these are simple tests you can ask the patient to say, do it, and then showing the examiner that I've done this. Okay. At the same time, feel for the tone of the thenar muscles and the hypothenar muscles. This is the opposition, which is done by the abductor pollicis and also the appendice muscle. While doing it, you need to give it resistance to the proximal phalanx level. Feel for the contraction of the thenar muscle. This is the function of the FPL. Stabilize the thumb and ask them to flex the IP joint. At the same time, the extension of the IP joint can be flexed. This is the extension of the IP joint. Examiner might be very interested to see how do you differentiate between a flexor pollicis longus and a flexor pollicis brevis. Function of flexor pollicis longus is all longus, they are large and their target is distal. So the distal joint is flexed by the FPL. Little ahead of is done by the FPL. So if they flex the MCP joint alone without the IP joint, it is flexor pollicis brevis. And if the FPL IP joint is FPL. These are simple technical things because they will not ask you what surgery you do. So that's all different part of the game. That's all for a hand surgery fellows. But for you to understand what is brachial plexus, these are things the examiner would like to know. And you're checking for the FDP of the index finger, stabilize the PIP joint, feel for the contraction. These are all self-explanatory videos. So Dr. Vijay wants to know how do you check isolated lumbrical? Anybody would make a guess? Function of lumbrical is they are the prime flexors of the MCP joint and extensors of the IP joint. So how would they do? How do you differentiate between lumbricals? Pure test for lumbrical. It's a very favorite question of Dr. Vijay. So the function is flexion at the ends of the joint and extension of the IP joint. If it's absent, if it is lost, what happens? It goes into claw hand. Yeah, come try, give a try. Vijay will explain to you. He does beautifully. Vijay can explain. You're right. So I think these are the technical examination questions which definitely an examiner would like to. So now the motor examination is over. So you come to diagnosis roughly by based on the motor examination. What is that injury? You need to complete the examination with sensory and at the last vascular examination and clinical side. So the sensory examination should start from the proximal. So you can make a rough guess which part I am testing. C5, very good. C6, very good. C7, C7, and then C8, T1. So this is one simple way of examining the sensory examination because most of the examination should conclude with sensory examination. There are times where sensory examination will help you to augment the diagnosis. This is the picture. So initially you are right, all of them are right. C5, C6, here part of it C6, C7 is over the middle finger, and C8 over the ring and the little, and T1 is over the middle aspect of the forearm, elbow, and then T2 is at the inner aspect of the arm. So this is simple way of one simple test to say that this patient has some degeneration apart from general signs that muscle pain. And the examiner might want to ask if you palpate a biceps in a recovering patient, they definitely have pain just because of the regrowth, reinnervation. And this one test you should always do. Look for this patient. Whenever I touch the biceps, it's pain. The paralysis or a weak muscle, atrophic muscle will not have pain. The reinnervated muscle will have always a pain. But for this patient, they classically say they have pain. I have pain. Means that's a good sign. So we have in our hospital this entire chart. All brachial plexus patients will have this chart filled, which is the where is the injury happened, mode of injury, date of injury, entire motor, sensory, and the range of complete examination, and then it comes to me for final evaluation. This one chart everybody prefer to keep for checking the root value. So you can make a quick guess. Whatever you've done is right. So on the left side, you see all the muscles we have checked are C5, C6. In between is the C7, which we have checked, and rest of the functions are all hand function of C8. Very easy not to get confused with this picture. Okay, so Now we will see the picture. This picture will not be confusing to you now, right? Look at the root level. What is given? Scapula now. What do you check for? Rhomboids and the rhomboids major. Difficult to check the levered scapula. And the long thoracic nerve by the peripheral. Now the picture is very simple and very easy. Now, once you come to the trunk level, what nerve you check? Very difficult to check the subclavius. Forget about that. Maybe ask there are other branches subclavius. It's very difficult to examine. So the trunk level is also done, and then the all the divisions they form the cord. We have done the lateral cord, which will check for the musculocutaneous part of the median nerve, and also the lateral pectoral nerve. We have the mnemonic as LML. The medial cards by the we have the mnemonic as MUM, the musculocutaneous. So the median nerve of the forearm, median nerve of the arm, the antebrachial nerve, and the medial part of the median nerve and the ulnar nerve. This is something in mnemonic we keep it as MUM. And then the posterior cord, we have the mnemonic as ulnar or ultra. So all these things are gradually checked. The upper subscapular, the thoracodorsal, the lower subscapular, axillary, and the radius. So all these things are checked. So this is the complete picture of the brachial plexus. Now we'll examine the brachial plexus, and then we'll come to a clinical way of examining the brachial plexus. Any doubts so far? You will get a chance to it. Okay, what I'll do, I'll post some cases for you. Okay, without seeing it, you will come to a diagnosis. Each one can take. I have 10 cases, all interesting cases. This is how you learn. So you can each one can come up and they can volunteer for a case. Very easy. You can just easily come up. Okay. Video is gone. Video is gone. Should I share with the OrthoTV or should I? इसको बंद कर दें, इसको खत्म हो जाए, can close that. और नहीं इसको one more surgeon who is there, we should also talk. But I have some videos. इसको वीडियो को सीधा play कर सकते हैं. देखना है, हाँ, यहाँ पे select करो. Already connect हुआ था. Yeah. Thank you so much. Okay, who is the volunteer now? We'll start from your friend. You can, yeah, or the other one. Oh, first. So watch the video just for you. Okay, watch it. You have some time. He cannot completely abduct it. Okay, keep saying cannot completely abduct, but he's trying to do it. What he's trying to do? He's trying to bless you. Look at that. He's trying to bless you and say something. I mean, say that something external rotation is happening. Blessing is something external rotation. He's trying to bless you. Is he flexing? He's flexing. He's pronating. He's pronating the forearm. Is he flexing now? He's not flexing. Okay. So shoulder, he cannot completely lift it. Shoulder is gone. But he's trying to initiate and flex you. So where is the level? The supraspinatus is at the apex point. So C5, C6. Problem is whether it is a avulsion or a rupture. In avulsion injuries, you will not get all those things. Closely watch. The shoulder function is completely taken by the C5. The C5 is gone. A part of suprascapular, which is because at the trunk level, the C5 and C6 both join together and forms the trunk. You understand that? And that trunk level, the supraspinatus is working. So C5 is gone. A part of C6 which forms the suprascapular is also working after the C. Triceps is working. Roughly put together, 7 is working. And here comes your part. Stabilize the shoulder. Should not, because the trapezius will start functioning. Yeah. So he is trying to initiate abduction and external rotating. No other muscle will do external rotation apart from teres and supraspinatus and infraspinatus. Okay. So, so the F's point is working. Part of suprascapular is working. Now I'm checking for the other functions. Obviously, triceps is there. The hand function we are trying to check. This is one way of checking the pronation. Pronation is not there. Supination is not. Obviously cannot be there, supination. I'm also feeling for the contraction of the biceps. Biceps is completely not there. Always check for the opposite side. So we could do pronation. I'm feeling for the pronation. He could do pronation, but he cannot do supination. See, he cannot do supination. He cannot do supination, right? This is taking for the brachial mid-prone position. It is there. It's a hand function. FPL is there. Median nerve is there. EPL is there. A part of radial nerve is working. The hand function is there. Finger extensions are there. And I'm checking for the FCR, palmar longus, and FCU. So you just need to ask the patient to touch the thumb and the finger, flex the wrist. You'll feel for the palmar longus and the FCR. FCR is on the radial side, palmar longus on the palmar side. So your diagnosis is hand function is good, forearm function is good. You cannot supinate and you cannot flex the elbow, but suprascapular is intact. Suprascapular is intact. Biceps he cannot do. Elbow flexion is not there. Supination is not there. Supraspinatus, infraspinatus is working. So what is the level? No. Anyone? I'll tell you, simple. Is C6 working? Very good. C5? Why? Part of C5 and C6 join together and form the upper trunk. From the upper trunk comes the suprascapular nerve. A part of it means that if biceps is not working, what is working? C5 is working. Understand? The C5, C6, they both join together form the upper trunk. And then it forms the lateral cord and then comes down. At the junction, the suprascapular nerve comes. So part of C5, if C5 works, then only suprascapular nerve is working. Because C6 is not working, because why? Flexion is not there. It's a pure C6. Understand? Why not a C5? Because supraspinatus is working as a part of from the upper trunk. We'll go to the other case. You got it? So you need to come with me for some time, then probably you easily go this. The second one. from the proximal to the distal. The second one. Please be seated. Watch the video carefully. Where is the lesion? Where is the problem? Problem is on the left side. His eyes are okay. Eyes. There's some ptosis there. You can see the eyes there. Ptosis. So all these are important finding in inspection. So there's a problem on the left upper limb. There's a ptosis. Something should ring your bell there. Okay. Watch that. Not like. These are jewels and diamonds. So on the right side, he is able to lift complete the shoulder. On the left side, could not do. He could not flex. He could not extend. Okay. So now, do you think it's a complete brachial plexus palsy? How many say there is a complete brachial plexus palsy? Because his ptosis, he could not do anything, no movement in the hand. So how many say they complete brachial plexus? You can lift, make all wrong choices the right choices here. Nothing is going to lose, but do not do it in the examination. So he says a complete brachial plexus palsy. Anyone goes with it, he says complete brachial plexus palsy. Any rest of them? Okay, we'll go ahead, see, watch it carefully. Watch the hand. Now I'm checking for the biceps. I'm checking for the tricep. Cannot do. They cannot do. Okay. Shoulder is not there, elbow is not there, forearm is weak. And what is good? Finger flexion is good. You're right. Finger flexion is good. This is not a complete brachial plexus palsy. Do not fall into trap just because patient is not doing anything. Patient will not move unless you check. That's more important. Look for the point. Look for distal. What is the position of the thumb now? See, this is the patient where you can flex the fingers. FDS is working. You think it's a complete palsy, but what happened to FDS? FDS is working. So these are all part of C8 T1. So C8 T1 is intact. Beyond that, not intact. So do not fall into trap. You have to examine completely till the tip of a finger, from the shoulder, from the neck, from the face to the tip of the finger. Sorry. Your examination towards that. Anybody says that it is a expert says that it is okay, so you check it by yourself and then only do that. If it is wrong, no problem. But examiners said that you know that you are examining the patient. That's not important. What Jay says is very important. You do a proper examination, nobody will fail you. Even your diagnosis is wrong. Understand? Nobody wants a diagnosis. Everybody wants how you examine the patient, how you come to a conclusion. This patient has a good function of the FPL, median nerve, a part of the ulnar nerve. So roughly in our term, we say it's a T1 hand. I think Vijay will understand. We have a good concept of T1 hand. Hand alone will function. With this, we'll do all distal nerve transfer and get a reasonable shoulder and elbow flexion. Got it? Interesting. Next, thank you so much. Next. So watch carefully. Watch carefully. Yeah? What is he doing? Flexing the elbow in supination. He cannot lift the shoulder, but he is flexing the elbow in. He's bringing the hand to the mouth. This could happen only because of elbow flexion. It's not trick movement, it's a pure way of checking elbow flexion. In supination, it flex. This patient is doing a perfect way of checking. What is not happening here? Initiation of shoulder abduction is not there and shoulder function is not there. Now you come to diagnosis. Triceps working? Very good. Watch the wrist. Very good. Very good. So these are subtle things you should understand. Okay. Initiation of abduction. Something is there. Initiation of abduction is there. So C5 is intact. C6 is working because exactly. Wrist is dropped. Who can tell the diagnosis now? I'll give a chocolate. Very simple, but interesting, fascinating. Fascinating. Radial nerve. Why the function? Why the hand? Why the patient cannot lift the shoulder? Radial nerve has any function on the shoulder function? No. Think little forward, little high, little proximal. Exactly. Exactly. Why posterior card? Tell all the mnemonics. Axillary nerve is not working, radial nerve is not working, and I checked the other dorsal, the lattice dorsal is also not working. So a clear-cut case of understand, because should not be carried away by like the shoulder is not functioning, elbow is flexing. What will be the diagnosis? C7 is not working. It's not C7. C7 will not alone be injured. Okay, so you should use a thinking. What is not working in the shoulder? Deltoid is not working. In triceps is not working, and wrist is dropped. So meaning to say that something proximal to the radial nerve. What is proximal to the radial nerve? Understand? You want to see the other function? All others are very self-explanatory. So I can see the bicep is good in this patient. Correct. Talk only on that mode. Don't talk with this median because they have fixed right. So this is a function of the ulnar nerve where they can flex the MCP joint, extend the IP joint. This is not the function of the extensor, long extensor. Long extensor should extend the MCP joint. You can flex the MCP, extend the IP joint. Function of the intrinsics. Okay, intrinsics are good. The radial nerve, the wrist extension, finger extension are absent. IP joint is good. If you go with this, you'll get confused. Oh, what median nerve is working, ulnar nerve is working, radial nerve is not working. So it's a radial nerve pulse. No, little proximal. You should always come from the proximal to the lower level. Any diagnosis should be proximal. What is there? What is there in proximal? Okay. Thank you. Next one. Another interesting one. This patient got operated a few days back. Few days back, operated. I can show you the video. Who is going to take a call? What's the name? Try lifting the both hand. Okay. Okay. Extend. Relax. Leave it. Okay. This you keep it in your mind. What is the one thing? See in the which watch this. This one thing is very interesting. See, One exactly. See, he's trying to good. He is lifting completely up. He's lifting completely up. The deltoid and all perfectly. See, you could see this. Once it crosses there, he's trying to lift a trick movement because of some muscle which is not working. It just falls down. That is the only thing. Triceps is the one thing which will keep the arm upper limb stable overhead, not the biceps. That's one critical point to understand. In overhead activity, the muscle which is more vital for stabilizing the elbow is not the biceps. Understand? Rest are self-explanatory. See, can he come? Why he is not completely able to keep the shoulder up like this? I can show you the video I uploaded last week. Is the deltoid good? How do you say good? This is the function of deltoid. Anterior deltoid, forward flexion abduction, middle deltoid, posterior deltoid. You can do this. Watch this. Watch this again. These are all initiation abduction. See, stabilizing the shoulder. This is a wonderful compensation of the supraspinatus muscle, not a function of a deltoid muscle. So he compensated for the deltoid by the supraspinatus and lift. Literature says that supraspinatus can only compensate for 30 degrees, but this wonderful compensation can even lift up to 90 degrees. Such is a wonderful thing of supraspinatus. But deltoid is the one need for overhead activities. Overhead abduction is by the purely by the deltoid. Initiation is by the supraspinatus. It can reach even up to 60-70 degrees. This patient does not have a abduction and simple. Where you will match? What are other things you check for the posterior card? Wrist is good. I'll come to that. You're right, triceps is weak, cannot lift. There's no wrist drop in this patient. In the previous one, wrist drop. So before commenting on axillary posterior cut, watch for the wrist. I'll show the wrist. The wrist is good. The wrist is not flexing there. It's not flexed. You see? Come here. Here comes. Good. Super good. Will you say it's posterior cut? Now think little lower. Little lower. So something below posterior cut. Something particular to the nerve. Only high radial nerve. What happens to high radial nerve? Does he have wrist drop? When specific. These are all questions for hand fellows, not for you. Think you can do it. Nothing, there's nothing impossible in the world. All possible things come from impossible. Think little. Triceps is not working. Wrist extension is working. Other functions of radial nerve is working. Now tell me. Correct. So it's a branch to triceps is not working. Isolated branch to triceps is not working. And isolated branch to deltoid, axillary nerve. These are all very, I have plenty of cases here. I can talk to you for a day. For quadrangular space, what happens is, problem is patient presents with pain. Pain is a more criteria rather than the weakness. This is a following injury. Some injury happened. So this is a classical case of isolated axillary nerve injury and branch to triceps. From the radial nerve or from the posterior cord, there are branches to the radial nerve. That branches are injured. So do not take away by previous video. Oh, posterior cord. Oh, axillary is not there. Triceps is not there. It's a posterior cord. Watch for the wrist. This function is good. So more specific. Interesting. You have time? We have nothing but time. Very good. Again, next, who is this? Yeah, very interesting. Come, make a guess. Don't jump into diagnosis. Keep it in your mind. What others will say? High median pulse. Why? Pointing index finger. No flexion at the thumb IP joint. No flexion at the index finger IP joint. So immediately you will say, exam, sir, it's a high median pulse. It's some deformity. Okay. Good. Obviously, you cannot be right in a situation. That's why we are here. So all the special tests for median now. This is how we check. You stabilize the hand. You ask the patient to abduct the thumb, check for the thenar contraction. This is how the abduction happens. At the same time, we should resist the proximal phalanx and feel for the contraction of the thenar muscles. Thenar muscles are like combination of abductor pollicis and appendice pollicis. We all, along with flexor pollicis, they form a bulk. Cannot do the FTS function here. Isolated. This is way you need to do for the FTS. Stabilize other finger. Ask them to flex the finger. Flexion at the PIP joint is the cause for the FTS. FTS is separated with the median. So this much we are very clear. So what is not clear is, we'll go ahead. So FPL is not working. So it's not a low median of pulse. It's something like high median of pulse. FPL is not working. The index finger FTP is not working. Now we'll come to it. Okay. Now. Got it. Okay. Now. Watch for this. I'm asking, checking the pronation and supination. Obviously, median nerve supplies the pronoid teres, so median nerve is not working. What is working there? Brachioradius. In mid-prone position, the brachioradius is contracting. And I'm asking to flex in supination. What is working? This is working. I could not feel any contraction in the back. What is working? What is prominent there? Check the video here. What is prominent? This is not biceps. I'm checking the forearm. That is bicep. That's weak, lax. Bicep should pop up something like this. Strong. Okay. So what's not working? Triceps. So nowhere it's high median pulse. Okay. What is this? Triceps is working. Good. Where are we now? Biceps is not working. He has a high median pulse. Who will tell me the diagnosis? Very simple, man. Start from the top. Start from the top. Okay. We'll go to the shoulder. Then you'll come. Wrist extension is good. Abduction is good. Shoulder is good. Now tell me that. We'll come in order. Okay. We'll come in order. Forget about this. We'll come in order. Is it a C5, C6 injury? Because good shoulder abduction. C6 doubtful. Because very good. C7 working. We focus on C6. Does C6 associates with median nerve? When? Come down. C6 forms as upper trunk. Upper trunk divides into two branches, anterior and posterior. C7 forms anterior and posterior. The anterior division of upper trunk and the middle trunk forms lateral cord. Lateral cord supplies the median and the median nerve and the musculocutaneous. Biceps and median nerve. Got it? So what is the problem here? Lateral cord. Understand? It's not a case of high median nerve palsy. Case of lateral cord. Why lateral cord? Why lateral cord? How do you come to lateral cord? Simple, I tell you. Shoulder function is good, C5 is not damaged. C6, why? Because biceps is not there. This patient also had high medial bicep. So there should be something problem with medial. CAT1 is good, so good. So it cannot be CAT1 injury. It cannot be a hand function injury. Okay, come little down. So C6 forms the C5, C6 forms the upper trunk. And from the upper trunk, there are two divisions, anterior division, posterior division. And middle trunk has two divisions, anterior and posterior. Both these anterior divisions forms the lateral cord, and that lateral cord divides into muscular putative and ligament. That is this calculation. So it's a case of pure case of lateral cord injury. I operated on this patient, perfectly doing well. But I have video distal nerve transfer. Is perfectly doing well. So these are the cases, really, wonderful cases for our case discussion. Little difficult to understand, but once you walk in through this sequence, you will definitely make an easy diagnosis in that case. Okay, last one. Okay, there are plenty, but last one very interesting. Okay, very interesting for you. There are some cases which you will also happen to see in the clinical practice here. Okay, good. You start with it. Very good, very good. What is functioning there? You can make it. Okay. What is contracting there? Just see. Mask. Exactly. Right. What is not contracting? I'm showing there. It's not popping out. So you could have made a guess now. This drop, brachial is not working. Not working. Just trying a trick movement. Triceps is not working. Hand is good. Finger extension is not good. Hand is good. No, hand is good. It's finger extension. See, there are introsseous. These are introsseous. The grip is good. Hand function is good. Introsseous are good. EPL not possible. Wrist drop, obviously extension is not possible. Other functions are good. See. Ulna now is working. Beautiful. So you said some ulna. Ulna is good. Beautiful. One simple test. Cross finger test. This is simple. So it is ulna is working. You may have some doubt in the median now. Median is working. Right? So any guess? What did you know? Triceps is not working. This drop, finger not extension working. Very good. The axillary is working. We haven't checked that, no. Without that, how can is? I say it's a posterior cord.
All the time saying, don't confuse with the nerve. How you only consider the root end. It's not a peripheral injury. You're confused with the nerve and the cord.
Okay.
You will give.
So now, I'll tell you, the deltoid is working. One more history. He had a satellite drinks. So now this history is helpful. So this patient had a binge of alcohol drinking on Saturday. Sunday he developed this injury. Crutch palsy involves deltoid. There, the part of the deltoid is involved just because it's proximal to the somewhere in the axillary now. So it's a high radial palsy. To be very simple, it's high radial palsy. Probably it could be at the groove or it could be above the groove because triceps is not working. What happens is I followed this patient because very known to me. He's a surgeon, a laparoscopic surgeon, obviously. A very close friend of mine. So I just put them on conservative and some electrical stimulation. And then so this was the pre-op video picture. And then this was the post-op picture. Deltoid is good. Pre-op we also deltoid is good. How is this movement is recovered? So there's no wrist drop. The biceps thick, there's no wrist drop. It's recovered, and elbow flexion extension all recovered. So it's a neuropressure type of injury. You might also get this injury in examination. Short case, 5 minutes. Diagnosis, treatment, nothing conservative. You might put them on some electrical stimulation. So his biceps working, triceps working, he's perfectly, absolutely normal. He's charming because he has consulted almost all consultations in Tamil Nadu and came to me finally. And that was his last destination. He's very happy. Again, he has gone back to binge drinking. So that's it. And thank you so much for your valuable time. I think hope you enjoyed. At the same time, learned something. It's very, volatile subject. Keep reading. I hope a day comes where one of you will become a brachial plexus surgeon, and we'll always be happy and proud to see that. Thank you, Vijay, for this wonderful opportunity. I think all credit goes to Vijay. A big applause to Vijay. Thank you so much.